It's funny standing up here. I feel like I'm back to the Feshki old days. I haven't stood on a stage since then, but I like this, with the lights shining on us. It's very warm up here, actually. Greetings to everybody, and I'm delighted to see so many friends and colleagues in the room, and particularly welcome my fourth-year student midwives over there. Lovely to see you. And a big hi to all of those back at base who are watching on, and to those who are looking from anywhere online. So it's lovely to be here. Yeah, I suppose I'm here to reflect the reality of I should have called this talk "The Dilemmas of the Director of Midwifery," because that's what I feel like I'm facing lots of days and lots of times. But on the end of the day, I'm 17 years doing this job, and I still love it. I still feel challenged every day by it, and I still feel energized and engaged by the job we do. But it is changing, there's no doubt about it. And I'm going to give you a whistle-stop tour, really, of some statistics, which are going to be a bit shocking, really, but also about some of the things we can do. I am talking about medicalisation of childbirth, and we talk a lot about the biomedical model, and it has a role. But I'm just putting it in the context of today's talk. There's a national decline in the birth rate since about 2011-12. When I reflect back to the early days of doing my role, there were 75,000 births happening in Ireland, and this year it's less than 60,000. But that change is going to that statistic is going to change. Looking at the CSO figures, in 2028 we'll be probably back up to 75,000 births. We're talking about the rise of complexity in the various talks earlier. Consumer expectations are changing dramatically, and again, that's reflected in our daily work, and I'll talk a bit about that. And the litigation and the impact on our practice is incredibly challenging. Influence of social media and the influence of fear, and that can be fear in clinicians and fear in the women who are attending our services. And I want to talk a bit about midwifery roles. I don't know if you know this, but you can now go and get a blood test at 6 weeks of pregnancy and determine if you're having a boy or a girl. It's a new technology. It's called Sneak Peek. You just send off a little blood test and you can determine your baby's sex with a 99-point-something accuracy rate. We're talking about commercialisation of childbirth. That's a bit shocking and scary to me that would be available so early, but maybe I'm behind the times and that should be important to women. I don't know. It just shows you where we're at, though, and I didn't know this until very recently when I was at a talk, and some of my obstetric colleagues pointed this out to me, that this is where women are seeking that information so quickly and so early. If you're looking at caesarean section rates, again, we've referenced this already, but now, this is IMS data. 2021 is the most recent on this slide, but we're over 36% on that slide, gone from 25% in 2008. And again, that's a really stark rise, and it's reflected in what's happening across the developed world, certainly. A lot of you may know about the Robson 10 groups. Certainly those of us in clinical practice will know about it. The WHO have taken this as a classification of caesarean sections, and Mike Robson works in our organisation. And I don't want to complicate anybody who doesn't know this table. I won't go into it in too much detail, except if you're looking at Group 1, which is the one I'll reference in a couple more slides. Group 1 refers to women who've had caesarean sections who are in the normal, straightforward, low-risk category. So they would go into labour spontaneously. They wouldn't be induced. So they would be normally women who are full-term and going into labour on their own. And if you look at, we have a lot of data, as a lot of hospitals have, but we're lucky to have a couple of people who are very forensic about data in our hospital. And if you look at these trends over 50 years, I feel like I was there from the beginning, but I wasn't quite. 1974 is the first year I'm referencing here. And you can see the dotted lines and the straight lines. So I don't want to complicate this too much, but the straight lines there are, and again, this is where I'm struggling without the monitor on my desk here. Group 1 caesarean sections are the straightforward spontaneous labours that I mentioned. So women who are coming into labour, coming to a hospital or in a home situation and having their baby. 80% of the clients attending us in 1974 were in that group. So all straightforward low risk women. And 20% were in the higher risk, in the induced category. So group 2 refers to induction of labour. If you look at the 2022 data now, so the broken line there refers to the caesarean section rate, in blue, and there were the women who attended in spontaneous labour and ended up in caesarean section. So you can see that the rate there at 2022 is around about 10%, 11% in our organisation. And the women who are induced, that rate goes up to 40%. The next slide there shows the other groups there, so I'm not going to, again, go into too much detail here, but the other slide with the green line, the orange line and the purple line refers to multiparous women, so women who've had a baby before. The green line is somebody who's been in spontaneous labour before and ends up with a caesarean section. The purple line refers to somebody who has at least one scar in her womb, so has had a baby by caesarean before. And group 4 refers to the women who have had a baby before and are induced or have a section before their baby is born, before they go into labour. You can see the changes in the demographic over those 50 years, and it's really, really stark now, because more women will be induced or have a pre-labour caesarean section than will have a spontaneous labour. I'm just putting up, that was me in 1986 when I started as a midwife. That is a picture on the right-hand side of our clinical report from 1992. And I just picked out some stats there to show you some of the differences over time. So if you're looking at the first green box there on the left, shows the number of women who've had a spontaneous vaginal delivery in 1992 was about 85%. And then it shows you the reasons why, maternal age on the right. Apologies if you can't hear me. Maternal age on the right, and it shows you that women were, the majority of women were in their 20s and early 30s having their babies in 1992. And it shows you the size of the biggest baby and the smallest baby. And the numbers attending the fertility clinic in 1992 were about 60. Women who attended the asthma clinic, we had very few stats on maternal medicine because we hardly had any maternal medicine at the time. It wasn't a recognised specialty. But 75 women attended for things like asthma or high blood pressure. So this shows you the stats of the caesarean sections in the women who attend with spontaneous labour versus induced labour. So the spontaneous labour group are creeping up a little bit. They're around about 10% now, 11%. But you can see how stark it is with the induction of labour group. And this is why it's so important, the work that Sinead is doing around antenatal education standards, because I'll reference time and time again, it is about information and power for women to make informed decisions. I just want to show you how we're doing internationally with the next slide here. This is group 1, so they again keep going back to, these are the women that mostly will encounter midwifery care. They're coming into full-term spontaneous labour without having their waters broken or anything else. They arrive into the hospital. And you can see Holles Street's rate there is just around 10%. I think this was 2021. I forgot to put the year of the slide, 2021 data. You can see Cyprus is nearly 20-something%, and Germany is very high there in terms of, these are women who come into spontaneous labour but end up with caesarean sections. So we're doing relatively okay, but that's not a great stat to be proud of, I think, when you look at where we're at in terms of medicalisation. We talk a lot about the rising age group of women coming into labour, and it is quite stark that women are now much more likely to be older having their first baby. And you might ask, why is that a problem? It's not a problem for the vast majority of women, but it's important for us to recognise that they are automatically being put into a high-risk group in terms of our management with guidelines. And again, this is where the guideline issue really, really pushes us to, you might argue, but some people would use the word forced care on women. We are putting people into a particular bracket because of their age. They may not necessarily have an underlying condition, but we're being told that we should offer this care because evidence shows that women in these groups can be of higher risk. So if you're looking there in 1990, where are we now? 1997, the vast majority of women were I mentioned they were in their 20s having their babies. In 2020, the vast majority of the women attending of aged over 35 was over, 30-something%. But it's the age over 40 that's really changing, I suppose. And they're the ones that are, we do need to look at as a group of professionals. You might argue that 40 is the new 30. Most of us are much younger, healthier and well in our 40s than we would have been 30 or 40 years ago when we were collecting this data. But at the same time, the way the guidelines are structured, we are being asked to treat these women as high risk, and they can't fall into midwifery care pathways when they're in their 40s. Again, looking at advanced maternal age, and it is a very hot topic for us because 12% of the women attending our hospital at the moment are over 40. So more women will be induced in our hospital and have a pre-labour caesarean section than will go into spontaneous labour. I never thought I'd see that when I started midwifery in the 90s in the National Maternity. But and there's so many factors for that, and I'll give you a breakdown. Obesity isn't really a factor. If you look at the bottom line there, it's about 10-11% of women. So obesity is a factor, but it's not the biggest factor. What are the key drivers? And this is a paper from Trinity with Sunita Panda and Cecily and Deirdre Daly's paper. This just talks about why clinicians, what are the key drivers in clinicians making decisions towards informed consent around caesarean section. And again, I don't have time to go into this, but it's really worth reading this paper. Personal beliefs, fear, hospital guidelines, and private model of care. And again, I don't have time to go into this, but my slides will be available. This is just showing the breakdown in the 30 years in induction of labour. And there are so many reasons for induction of labour, but a huge elephant in the room is maternal request. And I think we just have to talk about that, and I don't have time today to talk about it. And the impact in caesarean sections, I've mentioned that. That just shows you the breakdown of the fact that more women, again, will have a caesarean section because they're induced. Why is the shift? Again, I don't have, you could write, there are theses written about it, and I'd love a whole day to talk about this. But it's IVF, it's maternal request, but there's a huge element of it is the way we practice defensively. We are worried about medical legal situations or scenarios arising. We're worried about ending up in the coroner's court, and we are sometimes over-treating women because of that reason. Fear of something going wrong is a big one, and you know I do worry about this on a Monday morning after a bank holiday weekend when I come into work. I'm relieved when I hear, or on a Tuesday morning, I'm relieved to hear that there wasn't a bad outcome in the middle of a weekend when you know they might have had a busy night in the labour ward. Lack of expertise in breech birth and rotational deliveries is another reason why junior doctors will encourage women sometimes to have a caesarean section rather than try for a VBAC. This is showing you, we looked at the numbers of women who asked for a caesarean section, and 50% of the pre-labour sections were done for maternal request. And there's a whole list there of other reasons: maternal medical history, high head, placenta previa, etc. But the biggest factor, 50%, are asking for a caesarean section, and we need to break that down as to why that is. The ARRIVE trial has had a huge impact on our practice. This is the trial that was done in Boston, looking at 39-weekers and whether you could induce them safely and not increase your caesarean section rate. It did show in this trial that there would be no increase in your caesarean section rate and improved perinatal outcomes. It didn't, and this trial actually apparently said there were in lower frequency of caesarean section. There were 6,000 women in that trial, 3,000 in the expectant arm and 3,000 in the induction arm of the trial. I do want to go back and look to see was there a trial refuting that, because I do think that trial was discredited, but I don't have full evidence of that. But I do know that it is impacting hugely on our practice. Private versus public care. We did a study on this in Holles Street. You are twice as likely to have a caesarean section if you're a private patient. You're twice as likely to be induced, and you're more likely to have an operative vaginal delivery. Now, there's dozens of discussions you could have around this. Is it because women go that route because they've had IVF and they want to be assured that they have the obstetrician there if they have a problem? Is it because of poor experience in a previous pregnancy? We don't have that data, but it is fairly stark when you look at the numbers attending and their likelihood of having a section. I want to just mention this, like a man landed on the moon 50 years ago and we still can't start and stop labour. Like, honestly, what is it about labour that is so difficult? We don't understand physiology well, and we can't stop it, and we certainly can't start it well. So I have to give that credit to Caroline Brophy, one of my ADOMs, AMPs. We spend our lives talking about why is induction so tricky, why is it so difficult. The last couple, the implications for midwifery practice. We need more enhanced knowledge about morbidity, postnatal morbidity, mental health. Ursula's talk was excellent about birth trauma. We need to understand that more. We need to understand that more caesarean sections makes our resources be allocated in a different way. And we need to restore confidence in midwives. And we need to know that if women are attending an obstetrician, they're going to end up with more likelihood of intervention. The implications, does it matter? If I'm 40 and I'm only going to have one baby, does it matter if I have a caesarean section? This is what I hear some women saying to us. Maybe it doesn't for the individual, but it's looking at the overall practice for midwifery that it matters. Can we induce less? Why? Can we look at VBAC rates? And looking at the education for midwives. The last slide, I promise. I just want to reference the work Sinead and our team have done around the labour hopscotch, and that is published in the Anna's excellent journal, Practicing Midwife. And I referenced another slide there, or a picture there of Birth at Heart, which is Emily Wick's work that's being done on fear of, overcoming fear of childbirth and empowering midwives and empowering mothers. Thank you very much.